তো আমাদের স্পিকার যারা থাকবেন তারা বিভিন্ন বিষয়ে আজকে আপনাদের সাথে কথা বলবেন, তারা তাদের বিভিন্ন প্রেজেন্টেশন তারা আপনাদের সামনে রাখবেন এবং সেই সূত্রে আপনাদের যে কোনো জিজ্ঞাসা প্রশ্ন আপনারা তাদেরকে করতে পারেন। তো আপনাদের অনুরোধ করছি আমাদের কাছে কিছু সফট ড্রিঙ্কস ওয়াটার কিছু আছে, স্যার ম্যাম আপনারা সকলে সেগুলো নিন এবং কিছুক্ষণের জন্য ধৈর্য ধরে বসুন। আমরা আর কিছুক্ষণের মধ্যে আজকে এই সেশনটা শুরু করছি। যারা আজকে আমাদের সাথে এসেছেন তাদের আবারও অনেক অনেক ধন্যবাদ আজকে এই সময়টাকে আরো সুন্দর করে তোলবার জন্য। যারা পেছনে দাঁড়িয়ে রয়েছেন তাদের কাছে রিকোয়েস্ট করছি, প্লিজ ইউ ক্যান হ্যাভ ইউর সিটস। Everybody's there. Once again, good evening. This is Shahana and I would like to take this opportunity to welcome all of you. Thank you so much. Today आप लोग यहाँ पे एक साथ आए, हमें बहुत अच्छा लगा। আপনাদের আসার জন্যই কিন্তু আমাদের এই সেশনটা আরো বেশি সুন্দর হয়ে উঠলো এবং আজকের যে অ্যাওয়ারনেস আমরা ক্রিয়েট করতে চলেছি তার জন্য আমাদের মিডিয়া হাউস থেকে অনেকে এসেছে, তাদেরকে অনেক অনেক ধন্যবাদ। So we would like to start the session with Dr. Mayan Chakraborty. I would like to request sir to come here. একটা জোরে হাততালির সাথে আমরা স্বাগত জানাবো Dr. Mayan Chakraborty.
Good evening, ladies and gentlemen. A warm welcome to you to the Thalamus Institute of Medical Sciences. It is my great honor and I feel really privileged to welcome you all. And basically you know that this is World Brain Tumor Day, which was started by the German Neurosurgical Foundation to raise awareness and create early diagnostic methodologies to detect and diagnose brain tumor, because early diagnosis is the key for better prognosis in this disease. I feel extremely privileged to be amidst the august company today, and I am indeed very grateful to you for encouraging our attempt at spreading awareness about the presentation and management of brain tumor. Really, your presence motivates our team a lot. Through our discourse and deliberation today, and I must mention at the very onset that it was a day-long awareness drive, and we are in the second phase of the day-long awareness drive. And this awareness about brain tumor, I am sure that it is likely to kindle hope in people's minds and heart that they can thrive beyond the sentence of this diagnosis, because even in the 21st century, in many peripheral parts and even in urban parts of our country, brain tumor is nothing short of a death sentence. This misconception needs to change, because many tumors are there, many benign tumors are there, which will be seen throughout our discourses and deliberations, that many tumors, if I am allowed to name some like meningiomas, pituitary adenomas, they can be easily cured, and total removal is the cure. Surgery is the cure. There are many tumors in which you don't need radiation, but obviously there is a concept known as hybrid adaptive surgery, where maximal safe resection followed by other modalities like stereotactic surgery in the form of either gamma knife radiosurgery or sniper knife can give a good functional life to majority of the patient. This event basically has been curated to also spread the message that a patient is not alone, and that a helping hand and constant support will always be provided by teams in their journey to recovery and great health. I hope that you find your journey through today's itinerary useful, as we are sure that each one of you will become points of contact, gravid with knowledge after today's discourse and insight about this disease. I welcome you all wholeheartedly and thank you again for giving us the valuable time. I can guarantee that for all of us and for all of you, the evening is bound to be well spent. Thank you.
Thank you very much, sir. And we would like to start the session with lamp lighting, and we would like to request Dr. Arun Kumar Gupta sir, President IMA, Dr. Shankhu Sen sir, Secretary IMA, Dr. Malay Chakraborty sir, Chairman and Consultant Neurosurgeon, Thalamus Institute of Medical Sciences, Siliguri. We would like to request to come on the stage none other than our pride, Padma Shri Mr. Karimul Haq sir. Along with them, we We will have Dr. Tikanath Sharma sir, Dr. Shamaprasad Banerjee, and Sharmila Dey are one of the brain tumor patient survivor. একটা জোরে হাততালির সাথে আমরা সকলকে মঞ্চে আহ্বান জানাচ্ছি। নদীর প্রচলনের মাধ্যমে আমরা আজকের সেশনটা শুরু করছি। All the respected dignitaries, we are requesting all of you to come on the stage and light the lamp.
I'll request Dr. Mukherjee also to come for the light illuminating ceremony.
We would like to request Dr. Sumanta Mukherjee. আমরা রিকোয়েস্ট করব সকলকে একবার একসাথে সামনে আসার জন্য। স্যার সকলের কাছে অনুরোধ একবার করতালির মাধ্যমে আজকের এই সেশনে শুরু করার জন্য এবং all the dignitaries present here, thank you so much.
नमस्ते जी ओम नमः नमः शांति मैडम इटू सर इटू एदिके होटल सर इटू
Thank you.
Thank you so much. You have to give it to all the respected dignitaries present here. Thank you so much. Please have your seat. সকলকে নিজের আসন গ্রহণ করবার জন্য অনুরোধ জানানো হচ্ছে এবং তার সাথে আমরা মঞ্চে ডেকে নিচ্ছি ডক্টর A.K. গুপ্তা স্যারকে।
Hello. Good evening, respected chairpersons, seniors and friends. It's a great honor to me to say something on this auspicious occasion of World Brain Tumor Day in front of the learned gathering. It has been organized newly started Thalamus Institute of Medical Sciences under great care of Dr. Mukherjee and his very experienced team in the field of brain tumor and other neurosurgical cases. Every year on the 8th June, we observe World Brain Tumor Day. It was first observed by Deutsche Krankenkasse, a German NPO, in the year of 2000. Main aim of the day is to make people aware about the early and late signs and symptoms of brain tumor so that earliest care can be started. In any tumor or cancer, earlier the diagnosis, better the prognosis, and the survival rate. So this is the main target Early diagnosis gives us more treatment options with precise surgery and low side effects. This day, that is the 8th June, is not only centered on patients' well-being but also rehabilitation and support to those related to the diseased persons like family members, etc. About 3 lakh people die in India every year from brain tumor only. It is our duty as far as IMS Siliguri branch is concerned to spread the knowledge of early complaints, signs and symptoms in brain tumor patients in our society and guide them to proper health facility centers for early diagnosis and timely treatment. Dr. Mukherjee Chakraborty, whom I know since he was in Bangalore Institute of Neurology, Kolkata, and I was a PhD student in SSKM Hospital. He is very efficient surgeon and serving the people of this zone since long time. I hope the brainchild of Dr. Mukherjee Chakraborty, that his teams, will be a great help to people suffering from brain tumor and other neurosurgical complaints. Thank you.
Thank you so much to Dr. A. Gupta sir. And now we would like to request Dr. Shanku Shen sir to come here and say a few words.
সবাইকে নমস্কার। প্রথমেই মলয় চক্রবর্তী স্যারকে আমার কৃতজ্ঞতা জানাই। উনি আমাদের ইমিডিয়েট পাস্ট প্রেসিডেন্ট ইন্ডিয়ান মেডিকেল অ্যাসোসিয়েশন শিলিগুড়ি। উনি এবছরই ডক্টর অরুণ কুমার গুপ্তাকে স্যারকে প্রেসিডেন্ট পদ দায়িত্বভার দিয়েছেন। উনি জাস্ট ইমিডিয়েট পাস্ট প্রেসিডেন্ট। স্যার আইএমএর অনেক ভালো ভালো কাজ করে গেছেন এবং সেটাই আমরা যেন আরো ভালোভাবে করতে পারি। আমি আইএমএর সেক্রেটারি হিসেবে নতুন দায়িত্ব নেওয়ার পরে আমরা স্যার দুজন প্রেসিডেন্ট, এখানে সভাপতি স্যার আছেন, আমাদের খুব সিনিয়র মোস্ট সার্জন এবং আমাদের গার্জিয়ান শিলিগুড়িতে ডাক্তার সমাজের, এবং আরো অনেকেই যারা আছেন, অনুপ চক্রবর্তী স্যার আছেন, আরো অনেকেই এসছেন। সবাইকে জানাই যে আমরা ইন্ডিয়ান মেডিকেল অ্যাসোসিয়েশন শিলিগুড়ি আমরা এখন প্রচুর অ্যাক্টিভিটি বাড়িয়েছি। এর মধ্যে 207 জন নতুন মেম্বার হয়েছেন যারা এতদিন মেম্বার ছিলেন না। আমরা আস্তে আস্তে সবাই মিলে একসাথে যদি শিলিগুড়ির হেলথ কেয়ারটাকে অনেক ইমপ্রুভ করতে পারি, সেটাই আমাদের মেইন বক্তব্য। আমি নিজের ব্যক্তিগত অভিজ্ঞতায় বলতে পারি, আমি এমডি পাস করে 18 বছর হলো শিলিগুড়িতে এসেছি। প্রথমে যখন চেম্বারে দেখতাম কোনো পেশেন্ট আসছেন, সে ডায়াবেটিসের হোক বা একটা ক্রনিক ইলনেস যেগুলো হয়, কারোর কোলেস্ট্রল আছে, কারোর হার্টের ওষুধ আছে, সবার কাছে একটা বড় ফাইল থাকতো। সেই ফাইলটার মধ্যে কিন্তু আইদার ভেলোর অথবা চেন্নাই অথবা ব্যাঙ্গালোর এরকম বড় বড় প্রচুর কাগজ দেখে তারপর ট্রিটমেন্ট শুরু করতে হতো। 10 জনের মধ্যে 8 জনই কিন্তু ক্রনিক ইলনেসের পেশেন্ট তখন হয়তো বাইরে যেতেন। বিশেষ করে নিউরোলজিক্যাল পেশেন্ট বা নিউরোসার্জারি তো অনেকেই বাইরে যেতেন। কিন্তু এখন লাস্ট কয়েক বছরে, অন্তত লাস্ট 5-10 বছরে কিন্তু অনেক পরিস্থিতি চেঞ্জ হয়েছে এবং এই চেঞ্জের পেছনে নিশ্চয়ই এখানে চিকিৎসক সমাজ, বিশেষ করে যারা ভালোভাবে বিভিন্ন হসপিটাল বা বিভিন্ন সেটআপ গুলোকে তৈরি করেছেন, তাদেরও একটা বিরাট কৃতিত্ব আছে। তো এই যে চেঞ্জটা, যেখানে মানুষকে বাইরে যাওয়ার প্রয়োজনটা না হয়, যেটা ফেসিলিটি আমাদের শিলিগুড়িতেই এখন পাওয়া যায় সহজেই, এটা কিন্তু আমাদের শহরের জন্য এবং পারিপার্শ্বিক শিলিগুড়ি, জলপাইগুড়ি বা পারিপার্শ্বিক মানে আমাদের জেলা দুটো, বিশেষ করে দার্জিলিং এবং জলপাইগুড়ি, এই দুটো জেলার জন্য কিন্তু বিরাট একটা গর্বের জায়গা যে এত বড় একটি ইনস্টিটিউট মলয় স্যার তৈরি করেছেন। ওনার টিমের একটা ছোট পার্ট হিসেবে আমরা সবাই গর্বিত এবং এই হসপিটালের মাধ্যমে এবং আরো অনেক ইনস্টিটিউট এখন গড়ে উঠছে। শিলিগুড়ির হেলথ কেয়ার কিন্তু প্রচুর বদলে গেছে, আরো অনেক উন্নতি হোক, মানুষকে বাইরে গিয়ে অকারণে অর্থের অপচয় এবং যাতায়াত বা এগুলোর সময় নষ্ট করতে হচ্ছে না। পিন পয়েন্ট ট্রিটমেন্ট ম্যাক্সিমাম ক্ষেত্রেই পাওয়া যায়। আমাদের এখানে এখন ভালো ভালো ক্যান্সার ইনস্টিটিউট তৈরি হয়েছে, যেগুলো আগে ছিলই না, ভাবাই যায় না। আজকে নিউরোসার্জারির মতো ফিল্ড, কার্ডিওথোরাসিক সার্জারির মতো ফিল্ড সব বড় বড় মাল্টি স্পেশালিটি হসপিটালেই প্রায় হয়ে যাচ্ছে। এই শিলিগুড়ির এখন স্বাস্থ্য ব্যবস্থার যেটুকু উন্নতি হয়েছে তার পেছনে এরকম সিনিয়র ডাক্তার সমাজের যারা খুব সিনিয়র মানুষ, তাদের একটা বিরাট মানে অবদান আছে এবং সেই অবদানটার কথা মাথায় রেখে আইএমএ শিলিগুড়ির পক্ষ থেকে সবাইকে আমার স্যালুট, অভিনন্দন এবং নমস্কার জানিয়ে আমার বক্তব্য শেষ করছি।
অনেক ধন্যবাদ। যেরকমটা আমরা জানি, টু send the right message we need the right speaker and at the right time. আর আজকে সৌভাগ্যবশত আমাদের কাছে প্রচুর এরকম রাইট স্পিকাররা রয়েছে। And today we will be having one presentation by Dr. Shafi Ahmed Rizvi sir. So we would like to request Sir to come here for the presentation. একটা জোরে হাততালির মাধ্যমে আমরা স্বাগত জানাবো ডক্টর শফি আহমেদ গুজরিকাকে। Sir, over to you.
Good evening, everyone. First of all, I really happy that you have come here to join us to celebrate the Brain Tumor Day. I'm very grateful. My lecture will be limited to the area of discussion will be little bit different because we all know that brain tumor is going. If anyone has brain tumor, anyone if you detect brain tumor, the one myth is that this patient is not going to survive. This will die. So, just I would like to highlight what is the misconception and myths of brain tumor. So, my topic is, just for introduction, brain tumor is a localized intracranial lesion or mass with this abnormal growth. Brain tumor is entirely different of other part of the tumor because of the thing that there is a very less space to play in the brain. As compared to other part like abdomen or anywhere in the body, a lot of space are there, so they will give a lot of time as well. But in the brain, because of the limited space to play, the brain will get less time because of the less space in the brain. So now symptomatology, in short, that small tumor may be asymptomatic. Symptomatology are just it can be divided into generalized symptom or localized symptom or specific symptom. Generalized symptom like common symptom, there can be headache. Headache is the most common symptom of the brain tumor. Okay, followed by the seizure. Certain seizure is a specific, that is particularly in the low-grade glioma or like that. The seizure is the first symptom, but you need not to panic. Seizure, if the patient comes to you with the first onset seizure, that means it is a low-grade glioma. It is not a high-grade. Usually in a high-grade glioma, what happens is that headache and other symptom is the most common and most presenting symptom. If the patient presented with the seizure, first onset seizure, that means the patient has glioma, but it is low-grade. So there can be a chance of cure, not 100%, but after good surgery and proper gross total resection, we can send the patient to early radio and chemotherapy. So headache, seizure, nausea, vomiting, these are the common symptoms, but in the particular area, like is a specific symptom, like if a patient is having frontal lobe lesion, definitely patient can have a personality change. If it is a small tumor present in the frontal lobe, patient can have some difficulty in like patient having some cognitive impairment or some personality changes. There can be some, if the patient is presenting with you with a complaint of some personality changes or some difficulty in execution and like that, patient can have frontal lobe. Likewise, in the other part of the brain like parietal lobe, temporal lobe and occipital lobe, patient can present with a cortical blindness. Patient can have a tumor in the occipital lobe. Patient doesn't have any symptom like headache, vomiting, seizure, but patient can have a difficulty in vision. He may go to the ophthalmologist instead of going to a neurosurgeon or like that. Then after that he came back. So these are the tumor, these are the different type of, sometimes asymptomatic case. Some tumors are discovered incidentally during the imaging for the other issues. Patient may lie with the tumor without experiencing any significant symptom, like a small meningioma is there, he is having headache, okay, he comes to you and just for a routine checkup, we can get a CT scan done. we can find a small amount of small tumor in the frontal lobe like meningioma. Patient doesn't have it. You are supposed to repeat the CT scan after 3 months, and if the tumor doesn't grow, then you will not grow. Now a small benign tumor in the frontal lobe may cause subtle personality changes that I have discussed. Not just a brief classification, because it is not a neurological class. So just patient because this program is particularly limited to the general public, So just I have classified tumor into two. Usually it's benign and malignant, because benign is according to the American Brain Tumor Society, the benign 70% of the cases are benign, only 30% are the malignant. What happens is that if a patient is having tumor, then society is thinking about that this patient is not going to survive. 70 to 80% of the cases are benign, only 30% are malignant. In the benign cases, so many examples are there. In malignant cases, even in the malignant cases, there is a grading. The pathologist knows that grade 1, 2, 3 and 4. Even in the grade 1 or 2, if you detect early in the malignant cases, if you treat them early, then their longevity can be increased with the proper radiation and chemotherapy. This is just from this grade 1, grade 2. This is the WHO classification, grade 1, grade 2. If the patient came out to grade 1 and grade 2, the longevity can be increased. Now, main topic is what is the importance of the addressing the myth and conception. Myth and misconception surrounding the brain tumor can lead to fear, misunderstanding, and delay in seeking the appropriate medical care. So, dispelling this myth is essential. For the reason number 1, promoting the early diagnosis. Second, facilitate the informed decision, reducing the stigma of the disease, and enhance quality of the life. Now just come to the statistics. The percentage of benign just malignant tumor varies depending upon the factors such as age, gender, geographical location. According to the Central Brain Tumor Registry of the United States, the benign tumor is comprised of 70 to 75% of the tumor diagnosed in the adult. Malignant tumor constitutes only 25 to 30% of the cases. So this should go to the public, because I have said already that if the patient is diagnosed with a case of brain tumor, the public or they think that this patient is not going to survive. So if 70% of the chances that if the patient is diagnosed with a case of brain tumor, chances that 75% of the cases will be benign. The benign tumor, if will operate early, there will be complete cure. So my message is that don't get panic when you diagnose the case of brain tumor. That is the 70% chances that you will have a benign lesion. What do you mean? Brain tumors are symptoms. Brain tumor always causes symptoms immediately. This is the myth. Reality. What is reality? The symptoms of brain tumor can develop gradually and very gradually depending upon the tumor size, type, and location of the brain. Like if the patient is having a tumor in the frontal lobe, small frontal lobe, a patient doesn't have any symptom at all. Some personality changes can be there. Just like if the patient is having tumor in the posterior fossa, the symptom comes early. So usually it means that the symptoms of the brain tumor comes immediately. It does not imply to all the tumor. The symptoms of the brain tumor can develop gradually and very good depending upon the time. Some people may experience symptoms like headache, seizure, changes in the vision, behavior, and other may not be surrounding or floating in the society that always the brain tumors are fatal. Here is a complete cure for brain tumor. Second, advances in the medical technology, treatment have improved the prognosis of many brain tumors. Survival rates vary depending upon the time, location, aggression of the tumor, as well as the patient's overall health age. Some patients achieve long-term remission or cure, especially with the early detection and treatment. Second is what? Only older gets brain tumor. What is the reality? brain tumor can affect individual of any age, including children, young adult. Certain types of tumors are common in the specific age group. For example, medulloblastoma are common in the children, while GBM or glioblastoma are more common in adults. Now, alternative therapies can cure the brain tumor. What is this? There is no any scientific evidence that alternative therapy can alone cure the brain tumor. While some complementary therapies may help or may manage some symptoms, like I have seen in the remote areas in the village where we diagnose the case of brain tumor, and somebody says that you have a brain tumor, you are going to die. So what did they do? They went to a tantric or something like that. They said that this is the only thing that you can do right now. Don't go to medical science, don't go to doctors. They are not going to help anyway. So this is the way that we should make the public aware. And just I want to discuss the one case I have done 2 days back. Is a 2-year-old male child. He is having headache, vomiting, gait instability. On examination, GCS was stable. GCS was 50, and this is the pre-op scan. Okay, this is the pre-op scan of the patient. This is the pre-op scan of the patient. You can see here. This is the hypodense area in the CT scan. This is hypodense area. We got MRI done, in which you can see here. This is the lesion. This is a cystic lesion. Okay, you can say MRI. This is in the posterior fossa, in the cerebellum. You can say here. This is the mass actually. This is the mass. In the T2 sequence, you can see here. This is the mass. This is the mass. This is the cystic lesion. We have operated this patient, and it's an interesting case. This is the surgical video. I put up. You can see here, this is the cystic wall. You have drained the cyst. This is the cystic wall, in which you can see here the cyst cavity. This is cheesy material is there. We thought this is the epidermoid cyst. Okay, but what happens is that after that we can see here. Yeah, you can see here. You can see here. What is this? These are the hairs. These are the hairs in the brain. So this is the first case actually I have seen. That's why I have discussed here. Yeah. So this is the dermoid cyst. Actually, we thought that this is it can be the adenoid cyst or epidermoid cyst, but this is the dermoid cyst because this is the first case I have seen in which the hair is present. Okay, so this is a very rare case actually. Epidermoid is very common in the brain, but dermoid is very rare. So that's why I have kept it to show you. This is our hair. So we have removed it. This is completely benign tumor. So what I am trying to say, this is completely benign tumor. We have operated completely operated. There is no need to get any radiation, any therapy at all. He is going to survive. There is no any problem at all. So this is the benign tumor. So what the messages I want to say that all the benign tumor, if you will operate, patient is going to survive without any getting any extra medication, extra therapy like radiation and chemotherapy. This is the post-op scan. Post-op scan. This is no cyst at all. It is still cystic, net amount of hydrocephalus only will settle down. So what is the take home message? That all the brain tumors are cancer. This is the myth. Fact is most brain tumors are benign. 70% of the cases are benign. So this second, the brain tumor always causes severe symptom. No, it cannot, depending upon the location of the tumor. If I have said that if the frontal lobe has a small tumor, there cannot be a severe symptom. The brain tumors are always fatal. This is the most important, most myth floating in the society. We need to educate the society. This is most common. Many patients survive and life, fulfilling life, which already have discussed that in the benign tumor, 70% of the cases in the brain tumor is a benign, so can be cured without any deficit, without any difficulty. And even in the malignant case, if it came out to be grade 1 and grade 2, there is a great chance of longevity. So brain tumors are, this is the myth that brain tumors are caused by head injury. This is the myth. There is no any relation at all. Brain tumor can be prevented with diet and supplement. Somebody has asked me about the vitamin D3. Is it related to the brain tumor? It is not at all. There is no any evidence till date. Surgery, yes, surgery of the brain tumor always lead to brain damage. This is one of the most common myth that is prevailing in the society, that if the patient have a diagnosed patient, you have to diagnose the case, and if we educate the patient that if he needs surgery, they will ask that surgery. If you will do a surgery, patient which will not come out from the table. Third thing is chemotherapy and radiation always cause severe side effect. In fact, modern treatment are designated to minimize this side effect. And last one is alternative therapy can cure brain tumors. This is the only evidence-based medical treatment are proven effective. Like I have said that some patient with a diagnosed case of brain tumor go to tantric, and some in homeopathy and other pathies. They say, I don't discourage them, but they say that I can treat the brain tumor. It is completely absurd thing that they are talking about. If the patient is having a meningioma in the frontal lobe, surgery is the only option. No treatment going to help you other than surgery. So we need to educate the public regarding the myths which is going on in the society. Thank you very much.
Thank you so much, sir. আমাদের মাঝে একজন বিশিষ্ট অতিথি উপস্থিত রয়েছে এবং তাকে অনুরোধ করব মঞ্চে এসে দুটো লাইন আমাদের জন্য বলার। ডক্টর সুরেন্দ্র গুপ্তা স্যার, কনসালটেন্ট নিউরোসার্জন, স্যারকে একবার রিকোয়েস্ট করছি একবার মঞ্চে এসে কিছু বলার জন্য।
हिंदी में बोलता हूँ ताकि सबको समझ में आए। बंगाली आता नहीं, मुझे बहुत थोड़ा आता है। So basically today's World Brain Tumor Day. Why we are celebrating this? Because हम लोग चाहते हैं कि सोसाइटी को एडुकेट करें इस चीज़ के लिए कि ब्रेन ट्यूमर जानलेवा नहीं है और इसको हम लोग अर्ली स्टेज में यदि डिटेक्ट करते हैं तो उसको क्योर किया जा सकता है। अभी कई सारे लोग ये पूछते हैं, जैसे कि एक लाइन था मिथ में कि क्या इसको प्रिवेंट कर सकते हैं। तो दुनिया में ऐसी कोई चीज़ नहीं बनी है जिसको कि हम खा करके या जिसको करके जैसे एक्सरसाइज या फिर कुछ ऐसा करें जिससे कि ब्रेन ट्यूमर से बचा जा सके। नहीं, इसको सिर्फ हम लोग अर्ली डिटेक्ट कर सकते हैं और फिर उसका अर्ली पॉसिबल जो ट्रीटमेंट है वो करा सकते हैं जिससे कि इससे कम नुकसान हो और फिर इसका श्योर कि आगे ये ट्यूमर नहीं बढ़े, इसके लिए फिर डिफरेंट थेरेपी दिया जा सकता है। थैंक यू सो मच, थैंक यू सर टू इनवाइटिंग मी टू दिस प्रोग्राम। और बहुत अच्छा प्रोग्राम सक्सेसफुली गया है। हमें लगता है सबको अच्छा मैसेज मिलेगा, हमारे सोसाइटी में अवेयरनेस अच्छी फैलेगी। थैंक यू सो मच
सर, बहुत शुक्रिया। And now we will be having one more presentation on public awareness, and we would like to request Dr. Narayan Pandit sir to come here. for the presentation. একটা জোরে হাততালির সাথে আমরা স্বাগত জানাবো ডক্টর নারায়ণ পণ্ডিত স্যারকে।
Good evening, everybody. So, few basics of MRI. After before surgery, diagnostic part is utmost important. MRI is based on the hydrogen ion of our body. Hydrogen ion has got gyromagnetic properties, and in our body, the hydrogen ion arranged haphazardly. When we place our body in a magnetic field or apply our magnetic field, the protons are aligned, and we put the radio frequency pulse to disturb this alignment, thereby producing some energy, and that gives a signal, produce the MRI images. Now, safety first in MRI. All patients cannot undergo MRI without any preparation. Some materials are MRI safe, some are MRI conditional, some are MRI unsafe. Safe, like non-conducting elements, gold. Patient can go undergo MRI with gold. Non-metallic like wood, plastic, and non-magnetic items, patient undergo MRI. Some MRI conditional, some materials are MRI can be done in low MRI machines like 0.3, 0.5 Tesla, 1.5 Tesla, but if it is 3 Tesla or more, MRI, we do not know what will happen. Some are MRI unsafe. Now safe are nasogastric tube, IV cannula, IV tube, plastic drain, wound drainage, and unsafe. Unsafe are oxygen monitor, ECG pads, endotracheal tube, those are metallic, they are unsafe. Temperature probe, guide wire, metallic clips, ventilator, oxygen tanks are unsafe. Paramagnetic substances are all unsafe, like iron, cobalt, nickel, chromium, manganese. Diamagnetic substances are safe, copper, gold, and silver. Now, weakly paramagnetic can be considered safe. These things looks very innocent, but can become menace in the magnet. Like Jeep can cause some artifact, eyeliner, belt, like magnetic strips, ATM card, metro tickets, and may cause hazards in MRI. And this is the mascara, that is eyelash, coloring eyelash. This is dangerous. One of the patient has undergone MRI with mascara. The part of the orbit, anterior part of the orbit is not visualized. So before doing MRI, we ask the patient, please shampooing, shaving, and don't come with kajal, eyelash, liner, etc. Next, this patient came to our department for evaluation of parotid gland as a parotid swelling. We put the patient in MRI machine, there is signal loss. So we thought some magnetic metal is there, immediately put the patient in our CT scan. These are the nails. These are psychiatric patients. He puts the nail, perec, inside the parotid gland repeatedly, but nobody knows that. So MRI is abandoned, CT scan done. Now absolute contraindication MRI. Pacemaker was an absolute contraindication MRI in earlier days. But today, nowadays, some pacemaker is there, they are MRI compatible. Implanted pediatric sternal devices is contraindicated. Eye contact lens, metallic intra-orbital foreign body like some Sarraguli, metallic, is MRI contraindication, insulin pump are MRI contraindication. Now some basics. T1, T2, flare, diffusion, these are the MRI sequences. Now terminologies. We use the term hyperintense means bright, shada, black means hyperintense, and intermediate means isointense. Now how do you identify T1 and T2? Some basic words. This is the T1. T1 means the white matter is white, grey matter is grey. This is the white matter. Arrow is the white matter. This is the bright or white. This is the T1. And in T1, CSF is dark, meaning black. T1 is used for anatomic depiction, meaning total anatomy, and it is used for contrast image. T2. T2 is reverse. The white matter is black and grey matter is grey. CSF is white. And T2 is used for pathology depiction. And T2 and flare, these are the brothers. Only CSF signal is suppressed in flare. This is the flare, CSF is suppressed. This is used for periventricular pathology. And this is the GRE, gradient image. Calcifications and bloods are well depicted. And diffusion. This is a naked sequence. In this sequence, no skull bones or scalp. This is used for detect the restricted diffusion. Restricted means white. In acute infarct, it is restricted diffusion, abscess, lymphoma, epidermide, toxic, and metabolic incapabilities are restricted diffusion. This is the contrast. How do you identify? The vessels are enhanced. This is the no linear vessels, here is the vessel. So contrast is given. And MRI angiography. This is the anatomical picture, this is the MRI angiography picture. MRI angiography done without giving contrast. And MR spectroscopy is nothing but a graphical representation of different brain metabolites in ppm mode. NA, creatinine, protein. By this MR spectroscopy, we can grade the tumor at a high grade or low grade or benign. And we use the contrast media for to know the nature of the tumor or extension of the tumor, and we plan the surgery after contrast imaging. More advanced surgery, these are advanced tractography, how the brain fiber grows, and bold images. Some earlier days, X-ray was used to determine the brain tumor. Nowadays, it's not done. X-ray is very preliminary, particularly primary health center is used. This is one of the utility of X-ray. Lateral X-ray of the skull. This is the sella turcica, widened. There is brain tumor known as cranioparenchyma. This is a normal size, small. This is a big. So we are suspecting tumor here. And another case, that is density, increased density. So we are suspecting meningioma. And this is the skull lateral view of catheter view X-ray. This is the cavity. So we are suspecting eosinophilic granuloma or metastasis. Now CT scan. CT scan is a preliminary investigation of tumor. After CT scan is based investigation for calcified tumor. Once we suspect calcification, preliminary CT scan must be done. Otherwise, MRI can miss calcification. This is one of the CT scan contrast study. The posterior positive tumor. This is the extraaxial. This is meningioma. This is completely curable by neurosurgery. This is another brain tumor. On the right side, high grade glioma. This is, once we get this, we will die definitely. After some time, even treatment or without treatment. And this is CT scan, multiple lesions. This is brain tumor metastasis. Means tumor is anywhere, it has spread to the brain. MRI. MRI is the investigation choice of brain tumor. This is a good, brightly enhancing tumor in the right side of convex. It is a meningioma with a dural tail. Does not require any histopathological diagnosis. Only imaging diagnosis, patient is undergo radiotherapy. because hysterodynamis from the brainstem is not always possible. And this is tumor in the fourth ventricle, ependyma, and MR spectroscopy. Whether malignant or benign, from the MR spectroscopy we determine. And this MR partition imaging. And this is known as the mother-in-law's tumor. This is meningioma. The tumor blast appears early, goes late. And every PET scan is a clinical medicine. Thank you. This is simple doing.
Thank you so much, Dr. Narayan Patil sir. আমরা অনুরোধ করব পদ্মশ্রী মিস্টার করিমুল হক স্যারকে মঞ্চে আসার জন্য এবং কিছু বক্তব্য রাখার জন্য। এটা জোরে হাততালি স্যারের জন্য। কম বেশি আমরা সকলেই জানি, শুধু ভারতবর্ষের নয়, আমরা উত্তরবঙ্গের বাসিন্দা হিসেবে ভীষণ গর্বিত আপনার জন্য এবং অসংখ্য ধন্যবাদ, আমাদের আন্তরিক অভিনন্দন আপনার সাথে রয়েছে। এটা জোরে হাততালি ফর মিস্টার করিমুল হক স্যার।
নমস্কার। এখানে বলতে গেলে যারা বসে আছেন আপনারা সবাই মানব ভগবান বেশিরভাগই বসে আছেন। তো খুব খুশি, খুব গর্বিত, আনন্দিত একটা জিনিসের জন্য। আমি খুব শিক্ষিত নই, আজকে এখানে আমাকে মলে স্যার ডাকছেন। বক্তব্য দিব কি, এখানে যত ডাক্তারবাবু আছে যেভাবে কথাবার্তাগুলো বললেন সেটা আপনাদের ডিসকাশন, কিভাবে রোগটাকে নির্ণয় করা যায়, কিভাবে ট্রিটমেন্ট করা যায় শুনলাম, যতটুকু বুঝলাম ছবি দেখে, ইংলিশ তো বুঝতে পারি না। কিন্তু আমি বলি যে আমি একজন ডাক্তার। আমি ডাক্তার রেড্ডি আমাকে যখন নিয়ে যায় বোম্বাইতে, বেশ কয়েক হাজার ডাক্তার ওখানে চিফ গেস্ট হিসেবে গিয়েছিলাম যে আমি একজন ডাক্তার, কিন্তু আমি ওই ডাক্তার না, প্র্যাকটিশন লেখে নেওয়া। আমি ফার্স্ট এড ডাক্তার। রাস্তায় কোনো অ্যাক্সিডেন্ট হলে আমি সেলাই করে দিতে পারি। বাচ্চারা যদি বমি করে কিভাবে তাকে নিয়ে যেতে হবে, সেটা তো লাঙ্গের মধ্যে বমিটা না আসে সেইভাবে নিয়ে যেতে হবে, এইসব ট্রেনিং আমি দিয়েছি। তা খুব খুশি হলাম একটা জিনিসের উপরে যে আজকে ডাক্তারবাবুরা আজকে মলে স্যার একত্র করতে পারছে, সবাই ডিসকাশন হচ্ছে এটা কীভাবে ট্রিটমেন্টটা করে আগানো যায়। আজকে দেখুন আশপাশের ডিস্ট্রিক্ট আমাদের আছে বা রাজ্য আছে, আসাম, যে একটা দেশও আমাদের আছে, মাঝখানে আমরা আছি শিলিগুড়ি, একটা ইন্টারন্যাশনাল বলতে গেলে। এখানে আমি প্রচুর পেশেন্ট, বিভিন্ন জায়গায় আমি যাই, বিভিন্ন রাজ্যেও যাই আমি, হায়দ্রাবাদ, ব্যাঙ্গালোর, কলকাতা, বোম্বাই। আমি দেখি পার্শ্ববর্তী দেশের মানুষগুলা কিন্তু ওইদিকে প্রচুরভাবে ভিড় করতেছে, প্রচুর ভিড়। কলকাতায় বলেন, আরেন্ডাবাড়ি বলেন, যেখানে যাচ্ছি শুধু বাংলাদেশ বা নেপাল, ভুটানেরও ট্রিটমেন্টে যাচ্ছে। এমনকি আমি হায়দ্রাবাদ গিয়েছিলাম, সেদিকেও ওখানে আসে। তা আমি একটা খুব গর্বিত হইলাম একটা জিনিসের জন্য। বেশি দিনের কথা না, কাহিনী বলে অনেকগুলো হবে, আমি কাহিনী বলতে আসি নাই। বাস্তব যেটা আমি সেটা দেখলাম, দুটা জিনিস। 15 দিন মনে হয়েছে বাংলাদেশ থেকে আমাকে ফোন করে বলে যে আমাকে ব্যাঙ্গালোর যেতে হবে, আমার ব্রেন টিউমার হয়ে গেছে। তাই আমি রিপোর্টগুলো পাঠাইলো পিডিএফ করে। আমি মলে স্যারের ওখানে পাঠাইলাম। উনি বলছি পেশেন্ট না দেখলে হবে না, পেশেন্টটাকে নিয়ে আসলো আমার বাড়িতে। ওনারা ওখানে মেয়েটার পিছনে আমাকে বললো যে অনেক কিছু টাকা খরচা করছি, প্রায় 30 থেকে 40 লাখ টাকা খরচা করছি, এটা কিন্তু আমার ছাড়তেছে না। তাই আমি বললাম ঠিক আছে নিয়ে আসি পেশেন্টটাকে। মেয়েটা ক্লাস 10-এ পড়ে না, মাধ্যমিক দিয়েছি। মাধ্যমিক কি জানি উপসের ভাষাটা আলাদা, মাধ্যমিক পড়তে বলেনি। আমি নিয়ে আসলাম স্যারের এখানে, মালে স্যারের এখানে। তার কাকা আসছে, তার মা আসছে, ওরা ব্যাঙ্গালোরই যাবে আর কি, সেই সিদ্ধান্ত করে আসছে। এটা এক্সট্রা একটা দেখানো। আমি বললাম আপনারা যেহেতু ব্যাঙ্গালোর যাবেন দেখাইতে, এখানে একটু দেখান না, কি আছে তো অসুবিধা কিছু নেই। আর আমার বাড়িতে যেহেতু আপনারা উঠছেন, আমার এই অ্যাড্রেসে আপনি উঠছেন, আমি স্যার এখানে নিয়ে আসলাম। স্যারকে আমি বললাম স্যার এই মেডের পিছনে নাকি 20-30 লাখ টাকা খরচা হয়ে গেছে, আর এনারা ব্রেন টিউমার আছে, ব্যাঙ্গালোরে যাবে অপারেশন করবে, আমার কাছে বাজেট চাচ্ছে যে ব্যাঙ্গালোরে কত টাকা লাগতে পারে। তা আমি তো বলিনি। স্যার বলছি ঠিক আছে নিয়ে আসো। আমি নিয়ে আসলাম। নিয়ে আসার পরে স্যার দেখলেন, যেহেতু টেস্ট করলেন, করার পরে আমাকে দেখে স্যার হাসতেছে। তাই বললাম স্যার কি হলো, পেশেন্ট পার্টি ওখানে আছে। আমি স্যারের একটা জিনিস সেলেক্ট করি, তার সততা, তার বুদ্ধি বা জ্ঞান বোধ। আমি ওনাকে কিন্তু বলছি যে কয়েক লাখ টাকা কিন্তু আমার খরচা হয়েছে, তা আপনি এখানে ট্রিটমেন্ট করবেন? হ্যাঁ করবো। উনি রিপোর্ট দেখে উনি হাসতেছে। মেয়েটাকে বসলো, কথা বলাইলো, সব কিছু করলো। আমি এই ছবিটা দেখাচ্ছি, এই মেয়েটা আছে স্যারের পিছনে, ওনার কাকা আছে এখানে, বাংলাদেশ থেকে আসছে। ওনাদের বললো ব্রেন টিউমারটা কে বলছে, ওনার মা বলছে ওখানে বলছে ব্রেন টিউমার আছে। স্যার যেভাবে কথা বললো, ওরা ওখানে মানে অস্থির থাকতেছে যে কি ব্যাপার। স্যার বলছে যে এখানে ব্রেন টিউমার নাই, আমি মলয় চক্রবর্তী লিখে দিচ্ছি, এখানে আমার বাংলাদেশ বা পৃথিবীর কোথাও যদি কেউ আছে ডাক্তার দেখাই দিবা, এখানে ব্রেন টিউমার না, কোনো একটা রগ ভিতরে শুকে গিয়েছে, সেটাই কথা বললো। তারপর ওষুধপত্র স্যার দিলেন, দেওয়ার পরে আমার বাড়িতে সে দিয়ে বাংলাদেশ গিয়ে ওরা ঢোল পাঠায়। তারপরের দিন ওনারা চলে গেলেন। আমার মেসেজের পর মেসেজ আসতেছে যে আমাকে কি পুরস্কার দিবে, বাংলাদেশে আমাকে ডাকতেছে। তা আমি অবাক হয়ে যাই যে এইরকম ট্রিটমেন্ট যদি আমাদের শিলিগুড়িতে যদি আমরা দিতে পারেন আপনারা ডাক্তারবাবুরা, তাহলে পার্শ্ববর্তী দেশ কেন আসবে, ব্যাঙ্গালোর যাবে, কেন হায়দ্রাবাদ যাবে। মনীষ গোস্বামী জীবাটা অনেকটা কেটে দিয়েছে, বাংলাদেশে ওটাও বেশি ছিল ক্যান্সার বলে, এনারা কিনে নিয়ে আসলাম, ওরাও 15-20 লাখ টাকা খরচা করছে। আমার সমাজে একটু রিলেটিভ হবে, ওনাকে দেখলাম স্যারকে, পরীক্ষা নিরীক্ষা করলো না, যাই আদৌ ক্যান্সার হয় নাই, জীবনটা অবশ্য কেটে দিয়েছে। উনিও কিন্তু গ্যারান্টি দিয়ে দেন যতটুকু ওষুধপত্র দিচ্ছে ট্রিটমেন্ট হয়ে সুস্থভাবে ভালোভাবে আছে। তো এই ট্রিটমেন্টগুলো যদি আমরা শিলিগুড়ি দিতে পারি, কেন ব্যাঙ্গালোর হায়দ্রাবাদ বাইরের দেশে যাবে বা পার্শ্ববর্তী যাবে? কারণ আপনারা মেকার মানুষ, একটা মানব মেকার আপনারা, কিন্তু আমাদের অ্যাডভাইস করতে হবে, আমাদের মতন ছেলে মেয়ে যারা আছে অ্যাডভাইস করতে হবে যে আপনারা এখানে আসুন, ট্রিটমেন্টটা করুন। আগে জান তো দেখেন, ফার্স্ট যাবেন আপনারা, যান কোনো আমার আপত্তি নেই, কিন্তু শিলিগুড়ির মতো জায়গায় আপনারা যান। শুধু আমি বলবো যে মলে স্যার এখানে না, আরো অনেকগুলো নার্সিংহোম আছে, সেখানে আপনারা পরিষেবা দেন। এই সেবাগুলো যদি আমরা পাই, নিশ্চয়ই বাংলাদেশ, ভুটান, নেপাল থেকে যারা চিকিৎসা করবে তারা ব্যাঙ্গালোর মনে যাবে না, শিলিগুড়ি অনেকটা এগিয়ে আছে, এগিয়ে থাকবে। আমি চাই ডাক্তারবাবুরা যদি আপনারা এই পরিষেবাটা দেন, নিশ্চয়ই আমাদের শিলিগুড়ির নাম উজ্জ্বল হবে সারা ভারতবর্ষে আর কি।
জেলার বাসিন্দা ছিল বাংলাদেশে?
রংপুর, রংপুরের বাসিন্দা ছিল মোলাটোল, রংপুরের মোলাটোল বলে। ঠিক আছে,
অনেক অনেক ধন্যবাদ। আপনার সাহায্যের হাত যেরকম ভাবে এতদিন আপনি বাড়িয়ে এসেছেন, আগেও আমরা চাই যে আপনি ভাবেই সাহায্যের হাত বাড়িয়ে দেবেন, এবং আপনার মূল্যবান বক্তৃতার জন্য আমরা আন্তরিক অভিনন্দন জানাই আপনাকে। তার সাথে we will be having our next presentation on gadgets and patient care. For that presentation, I would like to request Mr. Ajit Palo sir from MINDRAY. We would like to request Ajit sir to come here. Welcome sir. And জোরে হাততালির সাথে আমরা স্বাগত জানাবো Mr. Ajit Palo sir from MINDRAY.
So, good evening all, and first of all, I would like to thank Mr. Malay sir and his team to organize such a beautiful event for the awareness of this brain tumor day. And I am Ajit, the product and application manager for MINDRAY Medical India. So I am representing MINDRAY here. So MINDRAY is a medtech company which is providing the medical equipment to all the medicals and in all the divisions. If you go through about our company, we are supporting almost in 90% across the globe, and we are having a very huge turnover of around 4.3 million, and our employee strength is almost 60,000 across the globe. So So that way we have got a very big R&D team of around 3,900 employees. The good thing about MINDRAY is we are investing almost 10% of the profit of the organization every year. So you can find new equipments every year. So our vision is to better healthcare for all, and our mission is to advance medical technologies to make healthcare more accessible. Some companies they provide medical equipments very high cost, so that will be something like a showcase. You can't use the technologies, and some companies they may not be provide the technologies. So by mixing both the things, we can provide the medical equipments at a lesser price and higher technologies also we are providing. So if I talk about our company portfolio, we are having all the equipments like we have vessel monitoring and life support equipments. We have got in IVD and medical imaging sector also, in the ultrasound division also we are having. So I am also thankful to this Thalamus team where all the three divisions, all the equipments are there. Starting from the ICU, all the ICU equipments are there, ventilators, monitor, ECG, DP, lights are there. If I go to IVD or your lab equipments, our high-end lab equipments are also installed here, and our medical imaging system, our ultrasound units are also here. So MINDRAY is doing innovation. It started in hardly 35 years back, but we are improving day by day, and all the products you can see started from a small patient monitor and it has gone to a very high level now. So these are the R&D center across 10 R&D center across the globe. We are having 1,900 employees, R&D employees are there, and we are investing almost 10% as I discussed, and we have almost 9,000 patent applications are there. Okay. The good thing about MINDRAY is that we have supplying 7 to 12 new products every year. Okay, so whatever your demand is there, customer demand is there, we are able to provide the same thing. If I talk about healthcare trusted partner, so we have started our organization in Gurgaon in 2007. Now everywhere in all the regions, east, west, north, south, our regional this is there, and our channel partner MEDS Subhadip is there, which providing this support, service support and the equipment support to all of you in this zone. So good the solution. I have the attendance service there. I am not discussing. MINDRAY has grown very sharply because of these achievements, acquirements. If you see the Datascope, which is an American company, I think if people are using the Datascope IMP equipment that is taken over by the MINDRAY, like the automatic technology. Sir is using in the ICU, so the CO2 monitoring and gas monitoring and that is the automatic technology. That also we have taken care. Like this Jonah is the ultrasound company we have taken over. So every year, either we are acquiring a company or we are expanding that way. So much higher. If you see the major milestone or breakthrough in all the hospitals, Southern NH Hospital, Narayana Hospital, which is using only the MINDRAY products. For last 8 years, whatever MINDRAY products are there, starting from MINDRAY, light table, pendant, anesthesia, and ventilators, and everything is used by NH by MINDRAY only. Like this, if you go to Apollo, Paras, Max, Fortis, Medanta, all the hospitals in our Eastern India, if you see Paras is a group which they are using MINDRAY products only. VML has started using all the OT and ICU products, high-tech medical college, some medical college, Medica, all these hospitals are using MINDRAY products only. So if you see, we are having an emergency care and transport products, perioperative care, critical care, and subacute care. All the product department we can provide the equipment to you. We have got a very high-end total ICU solution with us. The patient monitors, different types, starting from a small vital sign monitor to a very high-end premium segment monitor, modular monitors. We are having these things. If you see the modules, all the modules, starting from basic 5 para up to the RSO2, B's, NMT, PICO, everything is there with us. So if you go to any of the company, hardly you can find 3 parameters or 4 parameters. But whenever you are going to MINDRAY, they will be providing all the parameters in a single service. And our strength is about the different modules. Interrupt operating, we have got a transport monitors, ICU ventilators, very high-end ICU ventilators are there. and ECG is there, DPP is there. We have got a different type of DPPs are also there. And field solution is a new solution. Nowadays we have started talking about the smart ICU, and before 4 or 5 years we have started this field solution. M-Connect or smart ICU. I think nowadays it is a talk about that talk of the town is that smart ICU. What is that smart ICU? Because you people are so busy that you are not able to reach all the time to your patients. But when you are having a smart ICU, you can see all your patients simultaneously. This way you can see your patient. Suppose you are not there in Siliguri today and you are somewhere in Mumbai. By this connecting this solution, wherever you are there, through your mobile you can see your patient. And physically, if you have to see through a CCTV camera, you can see that one. Like this way, we have started lot of smart ICUs, and some of the doctors from like FMRI and all, they have started starting smart ICUs from other countries also, because they are not available simultaneously at India and other countries. They have started this solution. Now, if you want to start something other hospital, you are here and you can start around 40 or 50 kilometers, 4 or 5 hospital, and you have started a smart ICUs or smart hospitals there. You are by sitting here at the main hub here, you can see all the 5 hospitals, how your patients are doing. If something is going wrong, immediately you can see the in your mobile phone, you can get an alarm, you can get some patient is going down or giving some alarm, everything will come here. And if you want to see physically also, if CCTV is IP-based CCTV is installed on above the patient bed, then you can also see that one also. That is a feature of your M-Connect. Some hospital has started, and I want to say that Thalamus hospital has, by that time itself they started this mobile viewer. So by sitting somewhere, you can see what is going on with your patient at the ICU. Total over solution. So we are providing almost all the equipments for our operating room. We are providing the OT lights, OT tables, anesthesia workstations, ECG, DP, everything we are providing. So very high-end equipment so we are providing. If you see, starting from a 2-gas system up to the premium electronic gas mixing, everywhere all the type of equipment. As for the requirement, you can have the equipment. At a small hospital, you can have a 2-gas system. If you are going for a premium high-end electronic gas mixing, you can have this type of machines also. So whatever you require, we have got a solution for you. So we are always there to help you. And we have taken over a company for this endoscopy camera system, LGP, and we have got a 4K system also. This is a new baby. Last year's time we have got it. And we have got some good installation at Northeast, and we are planning to start demonstrations here also. If you see infusion therapy, and if days back it was having a very big equipment, now this type of infusion therapy equipment, whatever the ESP or USB, all the advanced facilities there, it is connected to your CMS also. If suppose you are sitting at the nursing station, you can see what is going on with all the nursing infusion pumps. At suppose bed number 1, 8 infusion pump is connected. By sitting at nursing station, you can identify which medicine is ending, which medicine is going to end, everything you can see here. So this can be also connected to the nursing station or CMS. So by if some other company, they are providing only the patient monitors connected to the CMS. But however, the MINDRAY, the ventilators can be connected, the monitors can be connected, the ECG DFib can be connected, and the pump can be connected. Everything can be connected. So it is a smart way. So that way you can connect. These are the solutions for the infusion pumps. Surgical table, we have got a different surgical table. Lot of surgeons are there, and so different surgical tables with all the accessories, starting from the Neuro to medical, all the accessories are also there. According to the requirement, different tables are there. Height with according to the height requirement and the patient table. Surgical lights, we have got a different surgical lights is there. Pendant is there, and if you see here, we have got equipment for your emergency room, for your all the departments, starting from the OR, recovery room, transportation, induction room, critical care, cardiology center, radiology department, and general ward, laboratory, and ER. So if you want to, you are starting a new hospital, all the department equipment can be provided by us. So we are not selling the equipment, we are selling the solution, we are giving you the solution. All the equipment can be bought from somewhere. So it is a single phone call away for you. So thank you. Thanks, sir. And any questions to ask? Mindray, welcome.
Thank you so much to Mindray and Mr. Ajit sir. Thank you very much. Now we will be having one more presentation by Dr. Tikanath Sharma sir. So we would like to request sir to come on the stage.
Without anesthesia, I think surgery would not have developed so far. With only anesthesia, the patient remains calm and quiet without pain, and the surgeon can do their work comfortably without any hindrance. And just a broader outline of stream management in the tumor patients. Basically, tumor patients, they all have a raised ICPs. Most of the patients, they have seizures. So basically, it depends. Basically, brain tumors can be either benign or malignant, or it can be primary or secondary. And it also depends on the location. The location is important in the sense that you have to counsel the patient accordingly. Which area it is, whether in the immediate most of them will have some problem or not, or during surgery also is important whether the surgeon is handling which part of the brain. Whatever the hemodynamic change in that brain drop, that is important. Have to be in the mind key, and pre-op also we can discuss with the surgeon his plan of surgery and what are the because basically anesthesia means surgeon also know better anatomy than the anesthesia. So we discuss about things, what is going to interrupt problems. Then anesthesia consideration, basically you have to evaluate the patients. Most of the patients with the brain tumor, they don't come only with the brain tumor. They have other associated findings. Like sometimes maybe have a heart problem, or sometimes maybe have a kidney problem, or sometimes maybe diabetic. So other problems. Before taking the patients, if it's not an emergency, you have to sterilize them. Then only you can take up for the surgery. Then again depends on if the patient is benign or malignant, and another thing primary or secondary. If the thing is secondary, you have to evaluate other system also. If you find out a ZEISS or abdomen or see if it is a secondary, then you can think move accordingly. Theory of management. Theory of management basically sterilization of the comorbidities. If the patient has uncontrolled diabetes, you have to control the diabetes, you have to blood pressure is uncontrolled, you have to sterilize it, cholesterol is uncontrolled, you have to sterilize it. So if they have a kidney problem, this also we have discussed with the different disciplines and sterilize the patient before taking up the surgery. And other measures like brain patient will come with basically your ICP is raised. ICP means basically brain pressure. The brain is inside a compact cavity. There is a skull bone is there. So pressure inside the brain is high with the brain tumor. Before taking up the surgery, we try to reduce that. Anesthesia technique, how you do it? Basically, patients with all brain tumors, they have a raised pressure inside the brain. So during making the patient unconscious, so it should not be very smooth. Patient should not move around. And there are different techniques. Either go for general anesthesia, sometimes we go for general anesthesia means we make the patient fully unconscious. And total intravenous anesthesia, the patient is partly unconscious. And another is monitored anesthesia. Monitored anesthesia is basically either the patient will be only monitored and only we give some sedation, patient will sleep it and will give some local anesthetic. so that the part of the knob will block, then we'll go for surgery. General anesthesia, how you go in? Okay, the induction has to be smooth and must take measures to avoid increased ICP during induction. Monitoring, monitoring all patients, basically nowadays, the anesthesists are advanced, we have everything to monitor during surgery. We monitor BCG monitor during the surgery, like blood pressure, both the blood pressure, there are two kinds of blood pressure. One is the from the cuff, one is the invasive, we put on a cannula inside the artery, then that gives the dynamic, very continuous blood pressure monitoring, so that it helps during the surgery, at least every second we can monitor the blood pressures. Then another thing, important thing about the neurosurgery is the positioning the patients. The importance of positioning is basically there are changes during positionings. Like some patient will get in position, the changes in the hemodynamics. Another thing, important thing is like the eyes, pressure areas, and some bond areas. So what happens during the positioning? We have to be careful about the pressure areas. Another thing, important thing is basically during positioning. If something like the neck is flexed and you cannot blood circulation is stopped and minimized, during surgery the brain will swell up. There will be difficulty in the surgery during operations. Another thing is during surgery, basically anesthesia principle is make the surgeons comfortable, because he is doing the surgery, so he must be comfortable doing the surgery. There are two things very important, like I take that is my philosophy. Patient safety and surgeon comfort is the utmost important during surgery. If the surgeon is not comfortable, you will not able to do the work properly. So that has to be maintained properly. And another thing, like usually during surgery there is bleeding, so the blood pressure goes up or down, that has to be maintained, and fluid and proper anesthesia. In the post-operative period, what happens usually depends upon the surgeon, anesthesia, the team, whether the patient will keep the patient on ventilator or extubate. That depends on the action of the surgery, the tumor location, and the team will decide accordingly. Then again, this extubation, like that is also taking of the flight and landing of the flight. Especially in between, there is not much a problem, but these are the two important things. Landing of the flight, if it is not smooth, the whole surgery done will go into mess. If at the time of the extubation, patient bucks or jumps or irritates, then again the patient brain will swell up, and the patient again, we might lose the patient. That is very, very important at the time of landing. At the time of the finishing of surgery, when the patient is coming around from the surgery, you have to be very, very careful. After the operation, usually the patient shift the patient in the ICU. There is a protocol, so the patient has to be at least in the post-op period, patient should not be irritable, at least the patient head should be a little bit raised so that the blood pressure doesn't go up. Then all measures like this patient usually can have a seizure in the post-op period, like convulsion, so that measure has to be taken up. Then another thing, the fluid and electrolyte, the neurological assessment, that is very important. Neurological assessment, what is meant by neurological assessment? That is neurological assessment, pre-op also we assess it, and the post-op also we assess it, whether we have damaged any part of the brain or not. That has to be assessed, and that has to be in the next period when the patient comes for a counseling, you have to discuss it what has been done. Then the patient goes on the ventilation. That depends on the team decision. We usually keep the patient make unconscious, paralyzed, and next day we do a CT scan. Then the team will decide if the patient go for more ventilation or wean off the ventilation. And we feel the patient is conscious, responding to the command. Then we try to wean off the patient from the ventilation. The final outcome of surgeon. Surgery is not the surgeon alone. It's a team effort. The surgeon is involved, the rest is involved, the OT staff is involved, the ICU team and the counseling team. Thank you very much. My short presentation.
Thank you so much, sir. Now we would like to request to come on the stage Dr. Mimi Gangopatra, ma'am. একটা জোরে হাততালির সাথে আমরা স্বাগত জানাচ্ছি ডক্টর মিমি গঙ্গোপাধ্যায় ম্যামকে। ম্যাম, ওভার টু ইউ।
Good evening, everyone. I'm here not to teach because I have very learned senior colleagues. So just a few words, what is my role in this hospital. So when a brain tumor comes out of the OD, my job is to say whether it is Amitabh Bachchan, a hero, that is a benign tumor, or whether it is Prem Chopra, a malignant or a very bad tumor. Sometimes it can be the Shah Rukh Khan or Basigar. That is, it may look benign, but it will come back again. So that is a tumor which will recur. So my job is to say, Maulai sir, who has done the main job, what tumor it is. And last but not the least, pathology can never work alone. I need the help of my radiology colleague, Dr. Pandit. I need the help of oncologist. I need the help of Dr. Sumit Agarwal, who is going to tell me the extent of the tumor, what was the state of the patient during surgery. So pathology can never exist alone. It is a multidisciplinary approach, and we all work together to identify and give the tumor its name. So the tumor comes to us, we all know pathology means what? Basically histopathology of the tumor, which is nothing but biopsy, as we all call it. It comes in small jars in formalin. And my job is to prepare that tissue or to put that tissue in a slide. So ultimately, in the lab, from that biopsy, we prepare this wax block, which is known as a block, and a slide. So basically, see, we are dealing with live tissue and we have made it alive, but put it on a slide, basically a photograph of the tumor. So how do I identify whether it's Amitabh or Prem Chopra? So I have to see the slide under the microscope. But to see it, we are very colorful people, pathologists. So what we do, we put colors. Basically we put pink and violet colors and we try to identify. But again, without the help of radiology, a pathologist can never identify a tumor. Then, as WHO classification kept on growing and the world made advances, we realized that there are many Amitabh Bachchan lookalikes also. So many tumors which look like Amitabh Bachchan but actually are not. We know maybe our budget is small, so at times instead of real Amitabh Bachchan, a lookalike has been brought. So we have to identify and tell. Why? Because on that depends the entire treatment of the patient. So what do we do then? So to identify the tumor, I'm not going into the details, we have to tell the surgeon or the oncologist how fast the tumor is growing, and if the tumor is growing, it needs food. So who will give the food? The blood vessels, who will bring in the oxygen? So we have to give these points to the oncologist or the surgeon. But then we saw that the pink and violet colors were not enough. So we have to go inside the cell to identify them. So what do we have inside the cell? The proteins. So we started identifying the proteins inside the cell with the help of a method which is known as immunohistochemistry. So we started long time back with histopathology and we evolved into immunohistochemistry, which gives us, instead of the pink and violet colors, the brown colors. And we know in medical college we have started immunohistochemistry. In the near future, we will surely start here also. So how do these brown colors help us? We identify where the brown colors are located. Inside the cell membrane, if we go to our class 10 biology, we know a cell has a cell membrane, it has a nucleus, it has a cytoplasm. So we see the location of these brown colors and try to identify the cell. And the main aim is to see whether the tumor is growing or not. So if we just look, I just gave a very small cartoon. A tumor which is not proliferating. Not proliferating means it's a benign tumor, good tumor. It does not grow fast. So see, the brown colors are almost zero. All the cells are blue. A tumor which is growing slowly is having only 3 brown colored cells. Whereas a tumor which is growing very fast has almost every cell colored brown. So this is how, with the help of immunohistochemistry, we say whether tumor is growing or not growing. Or in other words, whether it's Arpita or Prem Chopra. Next, so from CT scan or MRI, we evolved to pink and violet colors, that is histopathology, and then brown colors, that is immunohistochemistry. But the neurosurgeons and oncologists are just like eager parents. When a child is born in the family, what is the aim of the parents? They will put a horoscope and they want to know all the stars under the sun. What is the future of the child, whether the child is going to become a doctor, an engineer or a teacher. So they want to know about all the zodiac signs. So how, as pathologists, we identify the horoscope of the tumor? We do it with the help of how? We have to go to the DNA of the tumor. So we have to identify and break the DNA of the tumor and say all the molecules which are associated with this tumor. And how do we do it today? There are many tests. Most common is we use colors. I already said that pathologists are colorful people. So most common color that we use is fluorescent colors. So fish, fluorescent in situ hybridization. Or see, these are the fluorescent colors that we use to identify whether particular mutations are present in the tumor or not. Why this is important? Because now treatment does not only mean removing the tumor, it also means targeting those mutations. But as things kept on evolving, things became more complex. So now only saying 2 or 3 mutations is not enough. What has happened is, the latest is NGS, that is next generation sequencing. So for everything we have Gen Z, Gen Z, so on, as we learn from our children. Similarly, in pathology, the in thing is next generation sequencing. So now we sequence the entire DNA of the tumor and we can predict whether this tumor can recur, whether this tumor is malignant, what are the mutations associated, what are the syndromes associated. And so, in a nutshell, now a one-line report has become an elaborate report, an elaborate pathology report. So it is not only a histopathology report, it is a multidisciplinary report that a surgeon expects from a pathologist for brain tumor. So, in a nutshell, thank you, and again I want to stress on the fact that pathology is never complete without inputs from all the colleagues in the entire hospital. Thank you.
Thank you very much to Dr. Mimi Gangopathy ma'am. Now we would like to request Dr. S.P. Banerjee, Senior Consultant Surgeon. Sir, please come on the stage and আমরা আপনার কাছ থেকে ছোট কিছু বক্তব্য শুনতে চাই, আপনি এখান থেকে একটু বলুন প্লিজ স্যার, ইটস আ রিকোয়েস্ট। একটা জোরে হাততালি আমরা স্বাগত জানাচ্ছি ডক্টর এস.পি. ব্যানার্জি, সিনিয়র কনসালটেন্ট সার্জন স্যারকে।
Thalamus. I must appreciate they are conducting this show very well. And I'm pleased to be present here and listen to the speakers. But I've got doubts what they're talking, whether they're doing in the right reality, including pathologist, the minimum nuclear genome genetic study. I don't know what facilities he has got here. But my heartfelt thanks and blessings to Molo Chakraborty. I'm sure we will succeed in this classroom and the children are most welcome. So I bless them as well. Thank you very much.
Thank you so much all. দীর্ঘ সময় ধরে আমরা যার সম্পর্কে শুনে আসছি এখন আমরা তাকেই মঞ্চে আহ্বান জানাবো none other than Dr. Molo Chakraborty sir who took this initiative. আজকে আমরা এখানে দাঁড়িয়ে সেই কারণে সকলে একসাথে একত্রিত তার অন্যতম কারণ ডক্টর মলয় চক্রবর্তী।
Crowd is very thin. I feel that I should be very specific. See, the neurosurgery, few things we should realize. One is knowledge and wisdom. Second is, if you until and unless you think about the perfection, you will never be able to achieve excellency. And third is all and none phenomenon. Anything, time is very important factor in neurosurgery. As Professor S.T. Banerjee said that whether he is in doubt that these jobs are doing or not, in respect to that I would like to say anybody in the world, even Einstein, and you see Steve Jobs, Bill Gates, all these people used to feel two things. One is prayers. Prayers means practice. We have practiced our effort and knowledge since last 30 years. Then performance. Performance means meditation. Really we are performing. What Dr. Shofi has said in my eyes I have seen doing this surgery. So we are meditating now and we are really performing the surgery now. The Tikanath Sharma, excellent human being and anesthesiologist in my life I have ever seen in Siliguri. Mimi Ganguly has given enough impetus to make me stress-free to say that yes, it is the benign. You can refer the case to the other onco specialists, but they have come back to me again. Yes, it is benign. Today, Madam Surmila was here, whom we operated in the year of 2019. I think she should be here, I don't know. So we can really say that neurosurgery can be done very nicely, basically tumor surgery. I will show very quickly some slides. See, the World Brain Tumor Day you have known that German people have started, now everybody is doing. And you know this is the 6th common cause. And you know incidence is about 14 to 21 people per 1 lakh population. And you know immunosuppression, cranial radiation, neurofibrinoid disorder, genetic some things like that. It is already Shofi has mentioned our etiology and genetic mechanism is studying P53 is made but yet to be announced very correctly. And surgery is the definitive treatment. What should be the goal? You see, you should be always optimistic. You should not suffer from distress. You should be suffer from eustress. Anything which is available in this world, if it exists, 100% negative existence can be 100% positive, may not be today, but maybe after tomorrow. So this is what the machine which we are using. And this is the strategic location of Siliguri, you know this. And changes in scenario is, you can read it and you will understand what was in 1995 and what is till date. This is our hospital which is dedicated for the multi-speciality factors of this area, whole North Bengal and all the sharp countries around. So high-end robotic visualization is available to do the microsurgery in our hospital. High-end CUSA, microdebrider, all these things are available, and neuro navigation. If you can fly from Badogra to New York John F. Kennedy Airport, you can fly from surface of the scalp to anywhere in the brain inside. So this is the place where we are working. These are not false, these are not bluff, these are not pseudo. One can come to the internal operation theatre and can see that what we are doing. This is not a pseudo photograph, this is the reality. If you want to know something, all of you are welcome. Nowadays in some of the hospitals, the relatives can see what is happening inside the theatre. It is allowed and it is legally allowed. This is one of the brain tumor which is supposed to be meningioma, benign tumor. You see brain is under pressure, and if you know that if you keep it like that with some medication, patient will die. And if you do the surgery, patient will survive. Look at this patient has survived. Now look at this. This is basically another meningioma. So this patient histopathology is like that. Maybe it is a fibrocytic things. This is a post-operative, you see. This is again the histopathology showing angioplastic meningioma. So this is another patient. This is operating. This is meningioma. This patient was from Bangladesh. We operated. And this is the actually gliotic site, post-operative. This is a post-operative. This is the cerebellar cystic astrocytoma. This is the pre-operative MRI. This is another patient where it's supposed to be the glioblastoma, and it is post-operative. This is a pathological slide after 1 year. This is again another patient. You see the post-operative. This is youngest patient, 4 months old. This is another patient. This is the Fox meningioma. This is the MRI scan of that particular patient. This is the post-operative. See, this is the operation going on. So this you see, it's not very distinct because the light is not, there should not be light in the audience. I mean, what it is. This is the object. Now, this is the internal therapy. So it is the post-operative, that part is quite, not, tumor is not, no more there. This is another patient. See, we are now dissecting the tumor. We are going to Sylvian patient. And you can see, it is more or less bloodless surgery. Now we are inside the tumor. This is the CUSA we are using. This CUSA, that is jet-like water, is dissecting the tumor. And most important thing, I am always true to my word. Throughout my whole life I have done it. Very rarely I have spoken lies. Yes, I have spoken lies sometimes when I know the patient is at the last breath. I say, wait for another 24 hours. I know that the patient will go to die, but still, according to the Supreme Court law, I have to give a try for 48 hours. That time I am a little bit of diplomatic. Rest of the time I am never ever diplomatic in my life. What is written in the book, I try to say. This is post-operative. So I think you have understood. Much will be boring for you. I will just switch off. This is the person. Now this is already near about, this is near about 10 years before we did this surgery. This is a CP-angle tumor, I think you all know. This is again, we are decompressing the tumor. moving fast, right? This is the post-operative. This is another tumor. This is the post-operative. Turn the slide down. Start coming. See, this is the operation going on. So this you see, it's not very distinct because of light is not, there should not be light in the audience. I mean, auditor. This is optic. Now, this is the internal cavity. So it is the post-operative, that part is quite, not, tumor is not, no more there. This is another patient. See, we are now dissecting the tumor. We are going through sylvian fissure. And you can see it is more or less bloodless surgery. Now we are inside the tumor. This is the CUSA we are using. This CUSA, that is jet-like water, is dissecting the tumor. And most important things, I am always true to my word. Throughout my whole life I have done it. Very rarely I have spoken lies. Yes, I have spoken lies sometimes when I know the patient is at the last breath. I say, wait for another 24 hours. I know that the patient will going to die, but still, according to the Supreme Court law, I have to give a try for 48 hours. That time I am a little bit of diplomatic. Rest of the time I am never ever diplomatic in my life. What is written in the book, I try to follow. This is post-operative. So I think you have understood. Much will be boring for you. I will just switch off. This is the person. Now this is already near about, this is near about 10 years before we did this surgery. Volume. This is a CP angle tumor, I think you all know. This is again, we are decompressing the tumor. We are moving fast, right? This is a post-operative. This is another tumor. This is also convexity meningioma, like I said. This is a post-operative.
কেমন আছেন হয়েছিল কতদিন আগে মনে আছে কি অসুবিধা কি হয়েছিল
So what I would like to say, we don't need to advertise like Chennai, Vellore, these and these. The doctors are sending the patient to Mukilaben, doctors are sending the patient to here and there. We need the patient who do not have any money, they should come to us and we will operate on them.
হাত থেকে উপরে উঠাবেন, চোখটা বন্ধ করবেন, হাতটা নিচে রাখবেন।
These are some of the tumors. I just these are our team. Here, Dr. Sophie is there and other all people are there. My question is that these are all true, these are all facts. So, it can be done. If, you know, the, Robert Frost said that woods are lovely, miles to go before I sleep, miles to go before I sleep. I really feel that last 32 years, what I have done within myself in different nursing homes, they have not realized much what is the meaning of neurosurgery, what is the meaning of a subject. Eventually, we had our small hospital where we did everything. Now we need a state-of-art structure, not that people will come to me for the business and money, this and that. No, I don't believe that, as simple as that. I believe the work will answer my all feelings and philosophy. So now you see already in this hospital, I could have asked them to stay. Those people who have operated in this hospital, Mary Lecture, olfactory group meningioma, she was here in this morning session. So it can be done. This infrastructure, this hospital is definitely a gift to the North Bengal, and not only North Bengal but in this country. It's not that it is Malay Chakraborty doing something here. No, it's not. Anybody, any good doctors who is interested can come and work here. It is not my hospital, it is your hospital, it is the hospital of the society. So we have done everything because স্বামী বিবেকানন্দ বলেছিল জন্মেছিস যখন যাবার আগে একটা দাগ কেটে যা। কিছুদিন আগে 200 না 300 বছর বোধহয় আমাদের রামকৃষ্ণের যে সে ছিল হসপিটাল মানে মন্দির ছিল, সেই মন্দিরের প্রতিষ্ঠাতা ছিল। আমরা এটা ক্রিয়েট করেছি সবাই মিলে। ইটস নট দ্যাট এখানে সবার অবদান আছে, সবার। আমাদের এখানে যত স্টাফ আছে, ডক্টর টিকানাথ শর্মা কিন্তু আমার ওরকম সিনসিয়ার লোক আমার লাইফে আমি ইংল্যান্ডেও দেখি নাই। আমি এক ডাকে সাড়া দেওয়া মিমি গাঙ্গুলি যখনই বলেছি এসে দাঁড়িয়ে গেছে, কাজ করেছে। রেডিওলজিস্ট ডক্টর পণ্ডিত অল দ্য টাইম তাকে আমি ডিস্টার্ব করেছি। মানে মেইন ইনস্ট্রুমেন্টাল হচ্ছে প্রবাল ভট্টাচার্য and his elder sister who is my wife, Kaveri Chakraborty, Tanishta Chakraborty, Moinath Chakraborty, Mohinto Chakraborty, এরা সব এফসিটি সাফার করেছে আমাদের লাইফে, পুরো দিন সাফার করেছে। আজকে এখানে আমার মামা একজন আছেন জিএল মজুমদার, আজকে উনি নেই। Huge amount of work he has done. All the doctors, Sumit আছে, Dr. Sahu once upon a time gave us a huge amount of help. He is in different hospitals again. Anytime you can come and join. Professor S.P. Banerjee was philosopher and guide. যেদিন থেকে আমি হাসপাতালে ছিলাম সেখান থেকে প্রত্যেকটা দিন আমি ওনাকে কমপ্লেন করতাম, এই ভালো লাগছে না, এত কঠিন, এই সমস্ত কিভাবে কি করবো। উনি আমাকে চিয়ার আপ করেছেন। ইউ লুক ব্রাইট, ইউ লুক ফাইন, ইউ লুক ভেরি প্রমিসিং। ওনাদের সবার আশীর্বাদ নিয়ে, ওনাদের সবার ভালোবাসা শুভেচ্ছা নিয়ে আমরা সবাই মিলে এই হাসপাতালটাকে এগিয়ে নিয়ে যাব। আর আই এম ভেরি ভেরি গ্রেটফুল টু ডক্টর শফি, ডক্টর টিকানাথ শর্মা, মিমি গাঙ্গুলি, পণ্ডিত, যে আজ পর্যন্ত প্রথম দিন থেকে আজ পর্যন্ত তারা আমাকে টোটাল হেল্প করে দিয়েছে, আমাকে যথেষ্ট রিলিফ দিয়েছে। আর আমি আই স্যালুট টু দেম, আই বোড আপ। Thank you. I think I'll end up here. The reason is that I'll be more emotional, and second thing is that these things are all going on. This man is a Majid Shami, he's the world famous man for CP angle tumor, and if you are thinking all the time with cerebral cortex, you be a bit emotional. Emotional are those people who are understanding literature and science together. Thank you very much for patience hearing. I always welcome you. All of you are always invited and welcome to this hospital. Your blessings, your good wishes, your criticism, your anything are always accepted by all of us. Thank you.
Thank you so much, sir. এই থ্যাংক ইউটা শুধুমাত্র আজকের স্পিচের জন্য নয়, অফকোর্স আমরা সকলেই জানি শিলিগুড়ি এমন একটা জায়গা যেটা অনেকগুলো দেশ, তার সাথে রাজ্য সবগুলো একসাথে জড়িত, তাই না? দ্য হার্ট অফ নর্থ বেঙ্গল। এবং এরকম একটা ইনিশিয়েটিভ ইন আওয়ার সিটি, উই আর ভেরি ভেরি প্রাউড অফ ইউ। থ্যাংক ইউ ভেরি মাচ। একটা জোরে হাততালি ফর ডক্টর মহেশ চক্রবর্তী। এবং একটু আগে যে আমরা এখানে যে মানুষটাকে দেখলাম, ডক্টরের পাশে কিন্তু একটা অন্য পার্সোনালিটি আমাদের চোখে পড়েছে। যেটা একটা মানুষ যখন তার স্বপ্নের শীর্ষে পৌঁছে যায় তখন তার ইমোশনটা বের হয়। এবং তার জন্য আপনাকে অনেক অনেক শুভেচ্ছা, আমাদের আন্তরিক অভিনন্দন, আপনার সঙ্গে থাকবে। মে গড ব্লেস ইউ। আরো একবার জোরে হাতালি ফর ডক্টর মলয় চক্রবর্তী। আপনি এভাবেই এগিয়ে যান, আর আমরা সবাই সাথে আছি, শুধুমাত্র ডক্টর যারা রয়েছে তারা নয়, উই আর দি পেশেন্টস। তো অফকোর্স উই হ্যাভ টু বি দেয়ার ফর ইউ। এবং পুরো শিলিগুড়িবাসীর জন্য কিন্তু আপনি একটি গর্বের জায়গা। থ্যাংক ইউ। We have two more presentations, and the next presentation will be done by Mr. Nitesh Pathak sir. We would like to request Mr. Nitesh Pathak sir to come here for the next presentation.
না আসা শিলিগুড়ি নিয়ে যেতে হবে, এইসব ট্রেনিং আমি দিয়েছি। তো খুব খুশি হলাম একটা জিনিসের উপরে, আজকে ডাক্তারবাবুরা
Thalamus Institute and Dr. Mukherjee for giving me an opportunity to be part of this state-of-the-art hospital. And I think so this is going to be a long way in bringing the neurosurgery and spine patients. So basically what does so what does MEDTRONIC do? Basically, MEDTRONIC is into multi-specialities, therapy and medical things. But I solely represent the neurosurgery and spine. And basically, we have got neuro navigation system, which we have installed at Thalamus Institute, and that is the opportunity that I have got. I'll just play a small video for you guys. What is basically neuro navigation system?
More than the name of our system, its elegance and simplicity. It's the way you work. You are stealth. That's why we've designed the most advanced stealth station yet. From the second you log in, you'll know. A brand new interface so intuitive, it seems to know what you're thinking. Introducing Stealth Station SA. With the touch of a finger, enhanced 3D visualization lets you see structures and obtrusions with accuracy and fidelity. Stealth Station SA was created with your input, so workflows are built around the way you think, designed to make sure you get exactly what you need when you need it at your fingertips. Navigate with exceptional refinement and efficiency. Create models faster than ever with automated 3D tumor modeling and sophisticated new tools. The equipment you choose is a reflection of your work. Only the best tools for the best care. You are Stealth.
So that's basically the entire portfolio in neurosurgery spine that we have got. So you can basically see right from the planning, you can basically load a MRI or CT image of the patient into the navigation. You can look into a three-dimensional tumor images if you are doing a shunt surgery, or even if you are doing an advanced surgery. So how does navigation basically help? Navigation helps you in doing more of minimally invasive surgeries, and because like the patient base is increasing, like with the bigger setups, the number of patients diagnosed with brain tumors, those are increasing. This basically provides you more accuracy, more precision, and repetitive results. This is just a tool which basically helps surgeons to take decisions. Just like Dr. Malay said, it's like 30 years of experience that he is having. So it can never replace an equipment, but this is just an aid where in any of the critical patients, he wants to take a decision whether he wants to see a three-dimensional image. Basically, it will help us just in visualizing those tumors in a three-dimensional spaces. That is what basically navigation will help in. Navigation also helps in faster recovery of the patient because you have you have much more precise approach to the tumors, and basically so you don't make a bigger craniotomy or there is less blood loss. So basically patient recovery is fast. So you can pick more number of patients in your OR. So what is navigation? Navigation is just like a GPS system which we all have in our phone. It's the CT scan or the MRI is the Google map. The satellite is basically the camera of the navigation system, and the navigation itself is just like a device which guides you where the brain tumor is there and how much basically the path it takes. We also have another equipment which is called OARM, which is an intra-imaging device. So I'm just showing sir taking liberty that this is the next equipment which I want to place in your OT. So this is basically an intra-imaging device which gives you a CT scan images where you can bring the patient, take a scan, transfer the images into navigation system, operate it, and before closure you can again take a spin and take a corrective action if any screw or any correction needs to be done. So the patient immediately the next day can be discharged. You don't need to send the patient for a second X-ray or a CT scan post-op. The entire post-op thing can be done over here. So we are actually coming up with a 2D long film and 3D long film also in OARM, which basically gives you 46 centimeters of spine scan in a single spin that basically get. And just highlighting another thing, this is navigation. So navigation has got two platforms, one is optical and another is electromagnetic. Electromagnetic is where you don't need to pin up the patient on 3 pin and you can just continue. I think so in the imaging data when it was present, we spoke about tactography. So tactography is something which has been incorporated into navigation system. So you just need to have a functional MRI and you get this type of images with all nerve fibers around the tumor. So it basically helps the surgeon take decision on the table whether the entire tumor has to be resected or a part of the tumor need to be left out for better quality of the patient life. So I'll be running through these slides. Just one more product which we have recently introduced. It is like, I think so Dr. Miri was talking about the biopsy thing. So we don't need to exercise out all the tumor every time. There are tumors where we need to take biopsy samples. So this is our latest introduction, which is AutoGuide, which is a cranial robot which runs on the platform of navigation. And how does it help? It helps basically by making just 4 mm burr hole. So the same way the patient can be taken a biopsy sample and can be discharged. So all these gadgets basically is helping in faster recovery of the patient, shorter stay in the hospital and treatment by the hospital for more number of patients. So I'll just So that's it from my side, and again thanks Dr. Malay and Dr. Mayan for giving us this opportunity to be here and giving this talk. So, and congratulations for this.
Thank you so much to Mr. Nitesh Pathak sir. We are requesting everybody not to leave too soon. সকলের কাছে আমাদের রিকোয়েস্ট আপনারা একটু নজর ধরে বসুন আর কিছুক্ষণ পর আমরা আমাদের সেশন এন্ড করব but for the next presentation we would like to call Mr. Diptadeep Pal. Mr. Diptadeep Pal sir.
Hi, good evening everybody. Today is World Tumor Day. Everybody will see most of the things, what is the purpose of Tumor Day, what is the thing. So I sort the presentations, what basic brief of our product and what is the latest technology we have in our neurosurgery setup for tumor surgery and other things. I just show you one by one. I am Mr. Diptadeep Pal. I am taking care of the organized microsurgery business. So this is we are in 175 years old technology company which is designed for optics and other things. We designed for basically we have different technical like semiconductor manufacturing technology, industrial quality and research, medical technology and consumer market. So medical technology, we have a different division, ophthalmic setup and microsurgery for neurosurgery, TKD and others. So we have just expressed few of the technology which is related to the tumor surgery, brain tumor. We just show one by one what are the different modalities and products we are available, the latest technology. Like this is the microscope of different models that is already have. We have latest technology, robotic visualization system, Kinemo 900, Vivato 700, other things. Like show you the basic of how the microscope is look like. It's a basic video of the product which is available in the town and available for the neurosurgery and other things. Like this is the Vivato 700 workflow enhanced visualization system microscope, basically used for neurosurgery and other things. This is an ultimate long range Vivato 700. This is a very compact in design, auto balance technology, and all other integrated 3D 4K camera, monitor, and it has an option for tumor fluorescence. This is a new technology for tumor surgery, Palo 560 for tumor surgery, and also we have provided with IR 800 for vascular anesthesia and patency test for ventilation and other things. This is the 4K monitor. We can integrate it with our Vivato 700. So now we have a different attachment for basically used for neurosurgery, for ultimate reach and flexibility. Already we have discussed is a flexible overhead clearance underneath the certain standing and do surgery. It's a one corner or OT. You can place the microscope and you can say this is the latest microscope in worldwide with a larger working distance, 200 to 625, and it is a very unique graphical user interface which you can control every parameter of a surgery using the single touch. And you can connect with your iPad and any other gadget with Wi-Fi and other technology to control the microscope outside the OR also. You can see the surgical video from the surgeon room. So I just want to show our next product video, which is Kinemo 900. This is the Neuro robotic visualization system which is already available and we have successfully installed it in Thalamus Institute of Medical Science, and congratulations to Mukherjee and his team to use that product and give service to the patient, and they will give better outcome from the surgical procedure. And this is the product video which is available already not only in the Siliguri town, it's the first installation in entire Northeast and North Bengal area, Vivato 700. And the same microscope already have in any other premium institute, AIMS and all other premium institute, near about 150 installation in all over India. All the premium neurosurgery setup having this facility to give better outcome for neurosurgery or brain tumor surgery or other surgery. It has a very stable microscope, all axis, and it has a unique feature for point lock and position memory. You can locate the microscope, you can move robotically with any axis. And not only that, it has a position memory. You can recall the microscope when you need in between your surgery. It will be reduces your surgical precise time to do the surgery. And also a dual monitor. This is a 3D 4K visualization system is also there integrated in the microscope. Apart from that, it has a unique feature for micro inspection tools. It has a understand sterile design, simply plug and play. You can do 100-degree anatomical view with the deeper cavity. Like in cranial tumor or any other tumor, you just or aneurysm clipping, you have to double see or checking that clipping is perfect or not. After the surgery, you can have the facility to verify 1 second to get the better outcome of the patient, which is available already in Thalamus Institute of Medical Science. Name few of the gadgets which is available for our new technology. Like C, already we have your Kinemo 900 microscope. After that, check for ZEISS Convivo and treat for intraoperative radiotherapy. So Convivo, what's the Convivo is do? First of all, we just check the ZEISS Kinemo 900. It has help for tumor workflow. Inter-tumor workflow in a one single side. Like this is the microscope we can use. And after that, there is a pathology suite. Right? Dr. Mimi already said that we have need for digital, for histopathology, flogen section. He said we need more time. So we can reduce the time for get the easy outcome of the histopathology experiment. I come the next slide for detail about each of the product for tumor workflow. So like in tumor workflow, first of all you start like tumor workflow in detail brief. The tumor workflow is not only to remove the tumor. After removing the tumor, you have to understand its malignant or benign or whatever it is. After that, you have to do the procedure to treat that particular issue. So we have a solution where you can do entire procedure of tumor workflow, resection of tumor. Then after that, you can check the tumor is what kind of tumor, which is histopathology people are already doing using the progen biopsy. The same thing you can do using our 3 gadgets. So like in navigation guided already is there, you can diagnose this and your microscope is move automatically and locate you where the tumor it is. That's the robotic visualization system we have. So it is already located and identified, this is the tumor area. The microscope identified by itself. After that, it will be help the surgeon to do the new thing and do the surgery very confidently. And in video pathology source is the histopathology section, which is normally nowadays being a pathology section. But in our technology, it's a confocal technology. You can take in situ position multiple sampling in a single time and you can give a more accurate result. We have a cloud-based system. Any of the corner of the globe, the pathologist or neuropathologist can sit there. They can identify the on the ward direct image, live image, and they can give an instant cloud-based surgical system and they can give an output. And immediately they give a response to the surgeon within a second that this is what kind of tumor it is. So it will be easy to help not only for surgeon, it will be save the patient life on better way. And after the identifying, we have another gadget that is IntraWave 600. It's an intraoperative radiotherapy. But nowadays, it's give low milliampere X-ray radiation to localize tumor area. After dissection of tumor, normally we are doing for chemo or other radiation therapy. But it's such a on over table, you can give a radiation to treat the patient in a very faster and very convenient way. So this is the entire tumor workflow portfolio range we have, that is we consider, and after that we can show you different options like melting 2 word into 1 benefit. Like when you are using identify the tumor is came out, after that we use intraoperative radiotherapy. So where you can plan with medical physicists or medical oncologist and the surgeon. It's a teamwork of a total solution of tumor workflow. So they can plan how much dose is required for particular tumor in bed or what are the patient physics and patient condition and body weight. You can keep the localized radiation of this particular area. And not only that, it will be for specific parameters. We have a multiple parameter we can set with the help of medical physicists. Like this is the IntraWave 600. We have a different applicator there. So where in different position of the tumor and tumor bed, we have different size and different shape of parameters there. Like this is flat type, this is needle base or spherical. So depending upon the area of the tumor gap or tumor bed, you can set the particular applicator and you can localize, give the treatment. So you can control, it will be fully diagram based, track system integrated, everything will be digitally controlled on a OR or operation room. Outside the operation room or console, you can control this thing. It is easy to operate. Anybody in the medical physicist do the program in the system. After that, you can give a 30 minutes or 15 minutes time, and one shot after removing the tumor, in single shot, it will be cured. So whenever you are after that post surgery, 1 or 2 radiations later on, normally you can do this. That is the advantage of this thing is that normally after removing the tumor, we keep the patient for recovery. After that, we are planning for further treatment for radiotherapy or chemotherapy. So in between some of the nature of the tumor usually regrow in between the recovery stage or curing area. So this is the only option where you can on the ward table you can not only remove the tumor, you can treat the tumor bed and peripheral area also, which is malignant or non-malignant or anything is there. We have many installations in all over globe, but still we have a very few installations in India. It's a new technology. We are next planning to set an entire complete tumor bed solution like Thalamus, like this kind of institute. We have to give it a total complete tumor workflow solution in here. Now I can give you detail about how the CONVIVO, the in vivo pathology source, what is in situ in the OR, what the normally histopathology people are doing the same thing. You can use it on the OR with a very less time. This product video is short. I can give you in detail for better understanding. It's a in vivo pathology source. So this is a real-time feedback tissue microstructure through a digital pathology consultation. You can take n number of samples in a surgical workflow. You can add, and it's automatically given controller technology scanning the particular area, and this image and information transferred to the archival system, where real-time or neuropathologists, any of the corners in the world, they can diagnosis or cancer according to them. Multiple images they are taking sample, unlimited number. So after that it can be diagnosed and give a positive feedback, not only for one histologist, you can take multiple opinion of a neuropathologist who will give the multiple. Normally histopathology with one single or two samples, but here you can do multiple for verification in detail in shorter time. So now we are showing what are the latest technology and latest microscope, latest computer, latest infrared. The main thing is that if you take a world-renowned gadget, latest technology, we need the after-sales service other. So we have changed our service pattern with different gain, where customer get less downtime and accurate. Like what our service support is work like that. So it's a we are providing the
you need to photo line. This innovative digital service uses a secure connection between ZEISS and your medical devices in order to provide speed, support, and increased system availability. Even now, ZEISS Smart Services are included in service agreements for connectable ZEISS devices. ZEISS Smart Services are used when you or your staff have questions regarding a ZEISS connected device in the OR. Once you activate ZEISS Smart Services on the device, concerns such as configuration issues can be quickly addressed via remote desktop sharing. Another benefit is that the medical device with the changed configurations is immediately available. If for some reason a remote fix is not possible, you can send a diagnostic package with just one click. The remote engineer receives the encrypted error log files, analyzes them, and runs a diagnosis of the system, all without being on site. That way, the ZEISS remote engineer ensures that needed spare parts are available at the first customer visit. And that means the performance of the ZEISS device is re-established quickly and hassle-free. Enjoy easy and secure data connection to your medical devices with fast support and increased system availability. That's what ZEISS Smart Services is all about. And it's only the beginning. Our vision is bringing our customers additional services like advanced application support, remote software deployment, and much more. ZEISS supports you in realizing your ambitions and exploring new opportunities. Succeeding the smart way with ZEISS Smart Services.
Thank you everybody for giving us the opportunity to present our product. For the surgical application when inside the OR. After the installation, we do the application. After giving the application inside the OR, it's not coming. So when we install the first Kinevo in the entire northeast and hospital area, on the first day of OT, I present with Dr. Malacha Professor in the OT. So after getting the surgery, so what the satisfaction here is showing in the next few pictures. This is our Kinevo 900, the robotic neuro visualization system inside the OT. So next one, entire the ward staff, technicians and doctor all are present there. So this is the service explaining that this is the tumor and what's the image quality we have in our new robotic system. So not only there is the end and sir is showing interest to take it, we are privileged to that sir is standing inside beside our Kinevo 900 in the wall. So this is the dual monitor based robotic visualization system and sir is saying that this is the tumor we have removed this area. So thanks to everybody for giving us the opportunity to present our we are trying to organize business and long-term Thalamus Institute of Medical Science with some product new technology to give a complete brain tumor workflow solution in this institute. Thank you very much.
Thank you so much to Mr. Diptadeep also. After now we are waiting for the question answer round. If anyone wants to ask anything to any doctor, they can. Any question? Any queries? Can we have another microphone, please? Anyone wants to ask anything? Please feel free to ask her. No more questions? So all the doctors are the good students? Alright, then for the photo points, we would like to request Mr. Gerald Bernard.
Good evening, everyone. I'll take just 2 minutes. Please be patient. With deep gratitude, we extend our sincere appreciation to all who have contributed to the success of this event today. Heartfelt thank you to Dr. Malay Chakraborty, Senior Consultant, Neurosciences and Director of Thalamus Hospital. Mr. Bidhan, CEO of Thalamus Hospital. Dr. Tikanesh Sharma, Consultant, Anesthetist and Critical Care Expert. Dr. Safi Ahmed, Consultant, Neurosciences. Dr. Mayank Chakraborty, Neurosurgeon. And Dr. Kanishka Agarwal for their expertise and valuable insights. We extend our gratitude to Dr. A.K. Gupta, I am a President, and Dr. Sankasan, I am a Secretary, for their support and presence today. Special thanks to our event management team, Muskan, Kanishka and the entire WED Studio team for their planning and execution. We are deeply grateful to our sponsors from Sun Pharma, Mr. Diptadeep, all from ZEISS, Mr. Ajit Palo from MINDRAY, Mr. Nitesh Pathak, Mr. Bidhan Biswas and Ms. Arpita Mukherjee from MEDTRONIC for their great support. A big thanks to Mr. Sumitama Devashish Das and the team from FOODHILLS for their wonderful food and beverage arrangement. Lastly, a heartfelt appreciation to the entire Thalamus team, Saurav, Supriya, Asim, housekeeping, F&B, and everyone for their support throughout this event. Again, once again, I thank you for being a part of this extraordinary experience. Safe drive. Thank you.
Thank you very much. As I have made earlier also to send us a quick message, we need some good speakers, and today undoubtedly we had some great speakers. So put your hands together for all the great speakers, all the great doctors here. And thank you to all the audience, to all the doctors on respective dignitaries. We have organized a small dinner for you all. Please have your dinner. So we can end the session here. Once again, congratulations, Mala sir. आपने टॉनिक और शुभेच्छा तो आपका भी शौक हो गया आगे भी मेरे जो टॉनिक और शुभेच्छा and for contacting me you can search on social media, that is Anchor Shahana, the @ANCHORSAHANA. Thank you very much. Good night.